Welcome your hosts Caddy Frink and Aaron Fitzgerald as they lead discussions about substance use disorder and the journey to recovery. You're listening to Redefining Recovery, a recovery revolution.
Well, hello, you listening audience. I'm sitting across the table from one of my favorite people in the world. Who are you over there?
My name is Sue Hoisington.
Sue Hoisington. She's a lovely human being. I can hardly wait for this conversation. But first, I'd like to thank our generous funders, including the Patrick and Amy Butler Foundation, Otto Bremer Trust, the Sauer Family Foundation, the Hardenborough Foundation, alongside other many foundations, corporations, individual donors, and anybody who's listening to this podcast. So, what a beautiful day. The sun is out. Isn't it lovely out there?
Beautiful.
I know. It was a little rainy, and some events have taken place over the last few days that we are all just having to make space for in our hearts and our souls for. And again, my name is Caddy Frink. I am the Director of Programs at Minnesota Recovery Connection and the incredible dream come true host of Redefining Recovery, a recovery revolution. And across from me is Dr. Sue Hoisington. And what does your license plate say, Sue?
Dr. Seuss.
Dr. Seuss! When I first went to her house for something, this was during COVID times, and we were... I was trying to help her figure out how to use her computer because sometimes we have challenges with computers.
We do.
She said, just look for the SUV that says Dr. Seuss in my parking space. And I'm like, oh, there it is. I know where I'm at. So, Sue, who are you?
I am a doctoral level licensed psychologist and also an advanced practice addiction counselor. And I have helped at Minnesota Recovery Connection for, almost since the very beginning.
Like 2009-ish, 10-ish, like way back in the day?
2009 or 10, for sure.
Wow.
Yeah.
And what brought you, so what's your story? Are you a woman with substance use disorder?
No, I'm actually an ally, but both my dad and his mom, my paternal grandmother, suffered with alcoholism. And my mom also struggled with bipolar disorder. So I have a nice genetic mix of substance use disorder and mental health issues, which is really where my passion is.
Well, and I got to say, ever since I've had this delightful opportunity to work with Sue, I have learned more about myself and some of my own story and some of the things I was like absolute aha moments, and I've told her many times about them. No, she's not my therapist. She's my friend. But I get to have the advantage of having somebody who is as well educated and experienced in the addiction field say, that's real. That's a thing. And I think that's one of the things why I brought Sue in here, and that is mental health and substance use disorder. They are the chicken or the egg or the chicken, aren't they, Sue?
Yeah, I think, the question is it chicken or egg? I think it's both and. And I think that in many situations, chemical use, substance use disorder can cause mental health issues. It look like mental health issues like depression and anxiety when people are active in their use or when they're withdrawing. Sometimes I think people might use substances to help manage, keep the depression, the anxiety, and certainly the trauma out of conscious awareness. And I think that oftentimes we in the field have struggled to figure out which is which.
Yeah.
Is this substance use, withdrawal, or is it a bona fide mental health diagnosis?
And where do you think trauma fits into all of this whole picture?
Oh, trauma is very significant. I think we, not necessarily post-traumatic stress disorder. Not everyone meets the diagnosis for post-traumatic stress disorder, but I would say probably 75 to 80% of the people that I work with have some type of trauma in their lives that impacts their recovery, potentially.
Yeah. And I think it's one of the things that unfolded for me when I was, as I've just continued to have this incredible opportunity to kind of co-chair with you, and you do your magic and I just get to be there as a listener and maybe participate. And that is, is that my own life had some significant traumas, but I never put them together. And I think a lot of people don't necessarily put an event and maybe why they are using and say this caused this. And I really think, as you said, like the greater percentage of people have had traumatic events, either what we call big T's or little T's.
Yep.
And it really is part of the story about why people struggle.
Yep, absolutely.
Yeah. So you've been with Minnesota Recovery Connection and working alongside me for many years. Why did you partner with Minnesota Recovery Connection? What was that about?
Well, partly I was asked.
Okay, well, that works too.
And we were just beginning to understand, I think, the relationship between mental health and addiction. And I was a psychologist working at Hoisington at the time.
Good old Hoisington.
And several of the staff, I think, that were initially part of Minnesota Recovery Connection had been tethered somehow to Hoisington. And I think we had some staff that were on the board that helped develop Minnesota Recovery Connection. And I was asked to come in to dialogue with them initially about what a presentation on co-occurring mental health and addiction and substance use disorder might look like, and whether or not we were at a point, I think, in the field to begin to talk about that. Because if you think back, it really was the early 90s that we started talking about mental health and the impact that it had on substance use disorder. Before that, I think the addiction field thought that if people just worked harder on their recovery, went to more meetings, did more service work, that the depression or the anxiety would subside. And sometimes that was true.
Yeah.
And on the other hand, in the mental health field, we learned that, golly, if we just deal with the depression and the anxiety or the trauma, people wouldn't need to use or, alcohol or other drugs. And so I think it was really in the early 90s that we started understanding that there was some relationship between substance use disorder and mental health that was being untreated. So
it's amazing to me to think that it took that long to be able to say, hey, wait a minute. I've talked on occasion about my own mother who struggled with mental health pretty much from the time that she was aware of it and had to go through some significant mental health issues. She had anorexia disorder back in the day. She had, I know she had variations on bipolar and some anxiety, certainly anxiety disorder. And then she used alcohol to just quiet it all in her mind. And I didn't know what the heck was going on. She didn't know what the heck was going on. I mean, we would sit, because she wanted to be alone, she would sit and she'd drink in her place and I'd drink on my place, and we'd just hang on the phone for hours and just talk to one another. And that was some of our relationship. But, I didn't know what was going on. She didn't know what was going on. But we just sort of sustained a relationship and just sort of sustained staying alive for a while.
Yep. I think a couple things have influenced this. One is the stigma associated not only with addiction but also with mental health. And then also in the 90s, we started getting some new medications available, some new what we call psychotropic medications, which are used to treat anxiety, depression, bipolar disorder, other types of mental health issues. And prior to that, we had medications, but they weren't very good and they had some bad side effects.
Yeah.
Like, for example, the ones that were used for depression cause weight gain. And, if you're already depressed, to have a significant weight gain adds to the depression potentially. So I think let me add something here.
I think in one of the trainings you say that, and it also makes you constipated. So if you don't look good, you don't feel good, and you can't do number 2, you're not feeling pretty well. She would say that in my class, folks, and I would make everybody laugh. So I just thought I'd toss that out there because it's kind of funny.
Yeah, but I do think that changed, and it gave us prescribers freedom to use medications maybe less judiciously than we had prior to that. So I think that was also really important. And, the field, both mental health and addiction, had to really begin to work collaboratively together. I mean, I always felt like I was part of the team, and I always felt like we worked together. But I say early in my career, as a psychologist, I was sort of tolerated because it was part of the, 12-step model and the Hoisington model. And again, I got along well with everybody, but I think really our priority was addiction and it still is, getting people safe sober, in a recovery process. But I think we were naive to think that just all the depression and the anxiety and God help us, the trauma that people experience would just kind of go away, And I remember, in fact, it was one of the topics of my, or was the topic of my doctoral dissertation. We used to think that, particularly women, don't think we had the awareness about trauma with men. If we treated that too soon, that people would have a return to use.
Oh.
Because we would bring up the
hard stuff.
So just keep that suppressed or keep it under. Recognize that it's there, but just keep it under until people sustain some kind of abstinence and get a recovery program in place. But what we found is that people couldn't. The trauma was so significant and there was nothing to numb it. This is just an example. There wasn't anything to numb it, and they just could not stay sober.
Yeah.
So I think, I continue to say, and I'll say it a lot, if somebody has a mental health issue that they're struggling with, it can not only compromise recovery, but makes it very, very complicated.
Yeah.
And much more difficult, because recovery's hard.
Recovery is so hard.
It's hard. And then if you add an untreated, and I'm not saying everybody has a mental health issue. I don't want to give that impression. But if we have an untreated mental health issue, in addition to people early in recovery trying to put sobriety together and build a support network, it makes it really difficult.
Very complex. I mean, I know for years I had various degrees of probably just being down, because that's what it was called. You were just kind of down. You didn't feel like yourself. You didn't feel right. And a way to escape from that was to go and, go to the bar. That was my thing. And I think the thing about it is that when you talk about how if we don't deal with what made us down, then we just put a downer or an upper on top of it. We're literally just not helping a person move through it. And you got to talk about the pain. The pain has to be talked about, because if it's not talked about, it lives there. Mm-hmm. It just lives there in so many different ways. Mm-hmm. Wow. You're so cool. I just
Thanks, Caddy.
think you're so cool. So you walked into this world because you wanted to do things to probably maybe understand your own growing up and live with, sort of move forward. So you went to school where?
I got my undergraduate at the College of St. Teresa's, my master's in clinical psych at the University of Wisconsin-Oshkosh, and my doctorate at St. Thomas in St. Paul. And again, credit. I mean, certainly I have education, I have training, but much of my credit really goes to the clients that I've worked with, and really people like yourself, Caddy, and others in recovery who have been willing to share your stories and help me really learn and grow from that. And I'm grateful to everybody I've worked with. Again, I don't want to violate in any way, shape, or form confidentiality. I don't mean that way, but people that I've worked with that have really helped shape my opinions and help shape my beliefs and really increase my value and passion for the field.
Well, and I think I could get all misty-eyed with what she just said, but I'm going to hold it together. But I think that's the beauty of where we've come with recovery, and that is when we, the person who struggles with the substance use disorder, begin to talk about what has ailed us in whatever way, that's where what you now and I've really supported Minnesota Recovery Connection, but the field in peer recovery support, because it is truly that lived experience of both using chemicals and coming around to sobriety, then maybe evolving into recovery or whatever the heck your world goes to, is really where the magic is. And I think what's so interesting is that when Sue always talks about, when she does her mental health and co-occur training, she talks about how important peer recovery specialists are. And every time she says that, I see the students in the room that I get the honor of working with for an entire week go, wow, some lady with a doctorate gets us. And I'm like, and that's that really makes a person who might be in their early recovery wanting to give back to the community, and then somebody who's maybe been around the block for a while who wants to give back to the recovery community. It validates the fact that we do matter when we recover. and we have something to share. And we need people like Sue, and we need people like other LADCs. We need medical professionals. We need all of it. But man, when somebody can say, I get it, and it's hard and it sucks, but you can make it through. So we're about ready to take our first break. And gosh almighty, the fact that Sue is here just makes my heart sing. So when we come back from this break, I'm going to ask Sue just some more stuff about maybe who Sue is. And she's got some really cool stuff that she sometimes mentions and sometimes doesn't. So we'll see what happens. So thank you for listening to Redefining Recovery, Recovery Revolution here on AM 950. I will see you back in a few. Thank you.
This is just your passion, isn't it?
Hey, here we are.
This guitar needs 6
Welcome
strings.
back to Redefining Recovery, a Recovery Revolution. I am Caddy Frink. Sitting across from me is Dr. Sue Hoisington. She sounds so official, but she's just so cool. And I get to make her laugh just like that. And that to me just brings me smiles and giggles all around. So Sue's been talking about a professional that she is. Yes, Sue?
I was just going to say I wanted to add a little bit more to the peer recovery support specialist and the role.
Yeah, let's go forward on that one.
I always say, and I think it's true, that I have to earn credibility with people because although I'm an ally and I've been an Al-Anon and adult children forever, I need to earn credibility, but peers have an instant credibility, and their ability to bring hope and their ability with someone who's struggling early in their recovery to see that somebody can get sober and bring them hope is just phenomenal. And I think originally in the field we struggled with what to do with peer recovery support specialists, right? I've been in both the addiction and the mental health field and worked in both, and we struggled with what the role was. But I think as it's become clearer, this was early, right?
Yeah.
We didn't
even know what we were training back in the day. We knew that we were making people better, but what were we doing? Yeah.
The mental health field was a little more familiar with peer
support specialists,
not in recovery. And so it kind of started in the mental health field. And I think and again, I was working in the field then, but I think the peer recovery support specialists, when I worked at People Incorporated and now at Nuway, we've really integrated it very, very well into the lives of our clients, and it's made such a difference. But I think at first we kind of struggled with it. It's sort of like, well, they're professionals, right?
Yeah.
But they aren't exactly licensed. They're certified, but they're not exactly licensed.
Where do they fit? Yeah. So where, now that you're in Nuway and you've seen the evolution, and it really is an evolution of this field. I mean, since I've been training, it started off as a really great way for people to kind of look at themselves and look at the recovery, and they want to help people. But there weren't even jobs when I started training this. Now there are jobs, and there's things that have gone well, and there's things that have gone sideways, like most things do. But what, from your perspective, what have you seen maybe more lately, the impact of peer recovery services? What is it done? Well,
I think in addition to giving people hope and helping others believe that they can recover, it also has been an excellent resource for people to be able to identify resources in the community or to be able to share their own experience of, I don't know, whether it's a funding source or a housing source or a mental health professional or a case manager, an arms worker. I think that they play a very, very critical role in helping people talk about that and to set that up. And again, I think many peers have had their own experience with that.
Exactly.
Right? I haven't. I know it intellectually.
Right.
And professionally, but I haven't had an experience with an arms worker, case manager, for example. So I think it's to be able to bring their knowledge and experience in a very real way to people that very early in their recovery, oftentimes.
Yeah. Well, and I think that's absolutely target on, because I think what I see people who have the lived experience of coming out of their substance use, coming into sobriety, then potentially recovery, whatever their vocabulary wants to be, is that when I talk to somebody on the phone or I hear some of the peer recovery specialists, the certified peer recovery specialists we have say, hey, have you thought about this? or something as simple as, and I use this as an example, somebody who hasn't had a driver's license for a while, and maybe a counselor or a therapist say, well, you know, now you can go get your license. Well, I know what it's like having had a second DWI, having my license revoked, and having to go down to the DMV terrified and not sure what to expect. What is the judgment going to be? What's the stigma around me going to be? Because I had a DWI, not just some sort of other violation. And when we say, do you know what to do next? And somebody looks at you with that sort of like those kitten eyes and goes, I really don't know what the steps are. That's okay. We can walk you through it. Because sometimes it's been said time and time again in the training, you don't know what you don't know. And I think a peer recovery specialist can say, what are the barriers? What's gotten in your way? What is it that we can help you see through so that you can see it through?
Good.
And I think that's maybe what you've been able to identify that, and then it takes a whole lot of work off of some of the clinicians that are in Nuway or various places, right?
And again, I think that lived experience. Again, I can talk about what people might need for resources and ongoing recovery, but I think peers so often have that lived experience, and like you said, it's not just walking with them, but helping them understand, and sometimes even going with them.
Yeah, literally.
You know, like I know it's really traumatic or can be really difficult to go after a DWI to try to get your license. I'd be glad to go with you. I'd be glad to sit in the waiting room or whatever it is. And I think that's a really important role, as well as advocacy. I think peers, as you train them, Caddy, I mean, you have them for a week. I'm there for a couple of hours. But the advocacy that sometimes can kind of empower people that don't know if they have a choice or don't know, you know, sometimes they're so shame-ridden, they have so much guilt, and they don't know that they have a choice or that it's okay to ask or to expect even, right?
Well, they sometimes they're individuals that need to be given the opportunity to say it's okay not to be okay, but what will make it just ever so slightly better today? And I think that's where the magic is. I was just listening to one of our peer recovery specialists. She was talking on the phone with a woman last night for about an hour or so, and this woman was really struggling. She was having some child intervention with some of the systems, and she was just feeling really down and out. And one of our peer recovery specialists came up to me. She goes, it just felt so good because I've been through that, and I kind of know what it feels like to feel helpless, maybe hopeless. And I think this woman was even struggling with possibly going back to using her comfort, which was some sort of substance, because when you know what's going to be your friend, you're going to go back to your friend. Because those are paths that are just, I've said it before, and I'll say it again, and I'll say it a million times, folks, and I'm sorry if you get tired of it. But, you know, we get these hard and fast pathways that we're used to going in, that we know what to expect, but it many times doesn't end in a positive place.
Correct.
So what else do you want to talk about, Sue? She's got some notes, folks. She's got some stuff written down. What do you have written down?
I thought it might be helpful just to give some specifics about co-occurring disorders.
Please, yeah.
You know, and I think the literature suggests that 60 to 80% of people with substance use disorders also struggle with some type of a mental health issue. And of course, we know depression, anxiety, trauma are the most common. I thought it was interesting, too, that we found that with COVID, we've seen a significant increase in both depression and anxiety. But I also just saw some data that said that we've seen a 13% increase in substance use since COVID. In people that didn't struggle with addiction. They may not be struggling with it. They may not be addicted, but we've seen a significant increase in use, which, again, Caddy, goes back to what you were saying about how we cope or how we numb with kind of the loneliness or the grief and the loss that we don't necessarily talk about.
Right, yeah. So many things are hidden. So I want to make sure I understand that. So sort of a 13% increase in folks that were not known to have a substance use disorder, just an increase in use.
In general, right.
In general, yeah.
And I know that we've seen an increase in returns to use with many people who have sustained recovery because of, again, the same things we talked about, depression, anxiety, isolation, grief and loss.
Yeah.
And not really having a place to process that.
Yeah. Again, you just turned on a light bulb, Sue, because you do that every time I sit down and I get to have the opportunity to talk to you. And that is, think about folks who now we're in the third year-ish coming out of COVID, and maybe somebody picked up something, literally picked up a habit because we were shut down and away from people. And they might not have a person in their family at all that had any substance use disorder. And now all of a sudden somebody in the family is really struggling. And it's sort of like, hey, folks, remember, we've been through a lot. And it just sort of reminded me that somebody who was just, didn't have a strong friend group that they could get on Zoom with or get on the phone with or FaceTime with or text with, they might just go to the liquor stores, which were all open during COVID. And they had to be because it could have been much more devastating for those who were struggling with alcohol to close them. But we know the bars were closed, so that socialization was gone. So, yeah, what an interesting statistic.
Yeah. The other thing I want to just say, and Caddy, I say this when I train, many of us struggle with mental health issues, but it may be adjustment related. It may be related to something that's going on in our life, and it may dissipate with time. I think what I like to do is I like to say, how much does it interfere with your day-to-day functioning?
Right.
Because we can have people that have symptoms, and we can have people that have some mild symptoms, but how much does it interfere? And those are the people I think we need to pay attention to, or I try to pay attention to, because, like I said, recovery's hard. And you add an untreated mental health on top of that isn't, and boy, it just can complicate so much. And again, I think the shame, and we still do this with returns to use.
Yeah.
As hard as I think we've worked on that, the shame that people experience, and again, if that's something that really, I don't want to say it's out of their control because that's really not accurate, but if there's something else that's really weighing heavy on them, like depression or anxiety, that we can treat and we can help them work through while they're maintaining abstinence and on the road to recovery, that's what we need to do.
Yeah. Well, and then we think about the life events that happen, like somebody passes away or a dear, dear friend in Duluth got in a very, very traumatic car accident and has impacted their life. And so I believe this person's recovery is going to stay solid, but now they have a whole other facet of things that they have to deal with, which just brings that weight down on somebody. And so if somebody's struggling with another event that's happened, they've got a strong recovery, they've got things going on, they know how to take care of themselves, but man, drop a bomb on somebody like that, it would make perfect sense that somebody would go back to an activity potentially where they know they can get some relief.
Right.
And then if somebody is also dealing with, some sort of mental health concern, and maybe they've had it fixed forever and it's been under control, but a life event happens. And if, I've been through a fair amount of traumatic events in my life. And when I lost my father, very unexpectedly, it's going on a year ago, man, that just freaks me out.
Wow.
I thought about it this morning for some reason, and I thought, wow, I'm not going to think about that too much more, because I can know that in my recovery that if I dwell in the space of something, I could trip a trigger. But if I also move forward and say, is he happier? Yes. Am I okay? Sure. Do I still have 1,300 cookbooks I got to figure out what to do with? Yes. Dad, I love your cookbooks. Haven't just given them away. Got to figure it out, folks. But, it's just, there's these things that just happen in our lives that are both mental health, because I struggle with depression, have a little anxiety now and then have the trauma that was from the past, and now I'm going to be into 23 or 24 years of recovery.
Wow.
I know.
Congratulations.
Thank you. But how does this all play together? Well, it's a little bit of a juggling act. And then it's also awareness. And that's why we have people like Sue, where we can say, hey, I think I need a tweak. And that's what I mean. I mean that in a good way. Okay, that's a bad word in the substance use disorder world. I need a little help.
Tune up.
There you go. Tune up. Thank you. Because that's what I used to do back in the day when I had a therapist. I would say, okay, I need a little tune up, my friend. So we're going to take a break in about a minute or two. What's a statistic that would be interesting to the folks out there about mental health? And maybe when we come back, you know what I'd like you to walk into a little bit, Sue, is I'd like to talk about historical trauma.
Okay.
And where that comes from. Well, what's a statistic that is brand new to you that you just came up with, maybe?
Well, the number of people that have been abusing substances since COVID was.
Yeah.
I just was reading something yesterday, and I'm like, wow, of course that makes sense.
Yeah.
And that's independent of mental health issues that they might also have. But imagine somebody has an increase in depression and anxiety, and they have access to alcohol. And they're isolated. Again, we're fortunate, Caddy, because we have a recovery community.
Yes.
Right?
Mm-hmm.
Whether it's through Al-Anon or, for me, Al-Anon or Adult Children or AA or NA or a spiritual program.
All recovery meetings we have.
We have that.
Yeah.
And many people don't.
Oh, what a
Many
good point.
people don't have that. Many people just sort of keep it to themselves and think that they have to fix it themselves or take care of it, or they're weak. Mm-hmm. Right, but we really are blessed to have a recovery community and have each other we can just bounce stuff off of.
Somebody, yeah. Okay, now I'm seeing that statistic in yet another light, and that is it's that loneliness. If this is all brand new to you,
and the isolation,
and how now we've come through COVID, but now we've still got this hangy-on thing. Well, I want to thank everybody for listening. We're going to take a quick break, and thank you for listening to Redefining Recovery, a Recovery Revolution. Dr. Sue H. will be back in a minute. See you soon.
This guitar needs 6 strings, 'cause without it there's no song. And this house needs love in it.
Well, welcome back. We are here with Dr. Sue Hoisington, a good human that I adore at Redefining Recovery, a Recovery Revolution. And Sue wants to pick up the conversation talking about kind of recognition of the mental health and the crossover and the stuff, because this is her jam. Tell it to us.
I think, Caddy, lots of times people ask a question like, I'm diagnosed and started on meds too quickly, right?
Yes.
How do you really know how do you really know whether it's substance related? Because of my use and the consequences for many people, which would be kind of adjustment, right? We gotta clean up some of the mess that we've made as a result of our use. And how much is kind of withdrawal related, maybe? Because there's many ways that chemical use and withdrawal can both mask and mimic mental health.
Yeah.
And then there's some people that really experience symptoms and those should remit, okay? If they're substance related or they're withdrawal related, they should remit within a period of time. Now, by that month, 6 weeks maybe. And I wish we always had the luxury. I wish we had the luxury with people to say, well, let's wait 3 months and see if you're still struggling with depression or anxiety.
Right.
But that's gotten us in trouble, unfortunately, in the field because people have returns to use and then we have
and then everything is sort of like mixed up again, right?
Yeah. And I also hear people say sometimes, I feel like I'm a guinea pig. Right? The doctor just says, well, try this medication, it might help you, or try this medication, and it might help you. And what I want to say is it's not a perfect science, and we do our absolute best with the limited time that we have to really try to get an accurate mental health diagnosis and really try. And I always say, I don't get paid for the number of diagnoses I give you.
No, not at all.
My goal as a psychologist is to really help you understand if there's something else going on that might make recovery more difficult.
Yep.
We can treat it.
Yep.
We can try it. We can begin to treat it with therapy and begin to take a look at medications. And as I said, medications aren't all perfect and they have side effects, but they don't have the serious side effects oftentimes that we saw with some of the older antidepressant medications or anti-anxiety medications. So I think my answer to that or my response to that is if I can identify any period at all of abstinence that someone's had, and did they have symptoms of depression or anxiety? Trauma is a no-brainer. I mean,
That's there.
Yeah, trauma's there, and sometimes it is timing when we want to begin to deal with it. And would never encourage anybody to repress it or to keep it under, but maybe to keep it sort of
off to the side
until they have a recovery system in place and have some abstinence and have some support in place. So I think what I just want to say is that, again, I don't apologize at all for how mental health is treated, but I do think sometimes that we are quick to diagnose and we're quick to put people on medications. And we have to continue to work on that. And we need to really, again, do pretty accurate assessments. Oftentimes when people come to see us at Nuway, which is where I work right now, they're already on medications.
Right.
They've already had a diagnosis. They're already on medications. Or people will say, well, I was diagnosed with a bipolar disorder, for example, but nobody ever bothered to ask me if I was using methamphetamines.
Right,
right?
Yeah.
And so,
chicken or the egg, that's where that one comes in.
It's an inaccurate diagnosis, and sometimes we have to talk about that and say, well, if you haven't had any manic episodes or what we can perceive as a manic episode outside of use, likely isn't the bipolar disorder.
Right.
So we really try to see if there, I used to call it differential diagnoses, right? Where we take a look at the chemical and we take a look at any periods of abstinence that somebody's had and what did they struggle with, and again, to what extent does it interfere with their functioning? Right?
Yeah. No, and I think that's super important because I've, having been around you for as many years as I have, and one of the things that comes up all the time in class and that when we talk about this, and then sometimes when we talk about medicated assisted treatments and medicated assisted recovery, is like, well, all that stuff, all it does is, you're just putting people on more drugs. And it's like, there's a science behind all this. It's not just 'cause it's a science. And I think what I've learned over the years being with you and also hearing the community, and that is sometimes when somebody is actually put on a medication, the side effect can have another benefit. And I think that's one of the things that we have to take a look at. And if somebody's on a medication, maybe they're not getting, and I'm using air quotes here, better. Well, maybe we have to modify that medication because just like me on high blood pressure medication, it had to be modified a couple of years ago because my body changed. And I think what's important to remember in that is if somebody's struggling with a mental health issue and they might not be acting right and they're on a medication, which we have the perception that all medications will heal us from the get-go. No, they don't always. So we have to just be careful there, right?
And we also aren't very patient.
Not at all.
In my experience working in the field, and I too, I want it fixed. You want it fixed? I'm depressed. Give me a medication, and I want it to be better by the end of the week. And sometimes it does take longer for a medication to reach kind of full efficacy, or what we call, being effective in treating the symptoms. Sometimes that's 4 or 5 weeks.
Yeah. And imagine somebody who's struggling with some sort of mental health issue. They're not seeing the results that they want to. Guess what they might be able to do to make them feel better because they're still sort of crawling inside them skin. They might go back to using the substance where they know the end result.
Right.
It's the friend. So we have to be really careful if somebody is truly struggling with something and they don't necessarily hold true to their recovery or their sobriety. Hey, wait, hang on a minute. If somebody, falls off, let's not judge them harshly. Let's not, make them feel probably worse than they already feel, because anybody I know that's ever had a reuse, fortunately, knock on wood, I've not had a reuse, but I've thought about it because sometimes I know what to expect. And that's when these medications, we got to give them their breath of time and build in, like you said earlier, that recovery community. So when you're not feeling great, rather than go back to something that you know that will make you feel better, maybe we just got to twist and turn a little bit.
Yeah, and talk with your prescriber.
Yeah.
And, the other thing I want to just caution people is you should. It's best to not just stop a medication.
Oh, please note.
Because there are some residual effects that people are experiencing, even with some of the safer, what we consider safer SSRI antidepressants, the more common antidepressants. People are getting some well, I'm not going to go into it's not really withdrawal, but it's a side effect from the medication not being in the system, I guess is how I would describe it. So, and again, it's not life-threatening. It's not something that you're going to be hospitalized for, but there's wisdom why prescribers taper people down off of medication. And I think, again, the recovery community, I don't know, maybe everybody, but I think I've seen in the recovery community, it's not working anyway, I'm just going to quit taking it. Because people, and it might not be the right medication, it might not be the right dose of medication. One thing that I do want to say, and this has been, some awareness we've gotten over the last couple of years, is there's a test called gene site testing, GENESIGHT, that most prescribers have access to. And it's a mouth swab. And it doesn't tell the prescriber what particular medication, but it tells the prescriber what classification of medication might work best for you. Okay, we used to look at the family. They'd say, "Oh, Sue, anybody else in your family have depression? What are they on?" Well, we'll try you on that because of the genetic piece. We've gotten much more sophisticated.
We're so fancy now.
It's a simple test, and I believe most insurance covers it now. And it's not always conclusive, and it's not always helpful for people. But I think for individuals who have kind of hard to treat depression, that don't have kind of a normal response, rather than just giving up and saying, "Oh, God, I've been on everything."
Now what do I do?
Yeah, it might be an option for people to talk with your prescriber about that. So, because again, we want people to have the best recovery they can have.
Yeah. And when we as substance use users and current, past, present, whatever it is, we get frustrated. Yeah. And what I think about real quickly is, we're in a society where we're used to getting fast feedback on stuff. We got these cell phones that we swipe and we get happy every endorphin hit that we hit a kitty cat video like I do, or a whatever video, or we can turn on 9,000 different channels and we can, we want a quick response. And the body is exactly that, is a complicated mechanism that doctors and scientists and pharmaceutical companies, for their good and their ill, they're just working with what they know. But it's communicating with your healthcare professional, communicating with your peer recovery specialist, saying, "You know what, I'm not sure if this is working." And no peer recovery specialist, no certified peer recovery specialist is ever going to tell you what you should or shouldn't do. But because many of us have had this crossover with co-occurring, we can say, "Hey, you know what? I got you. I remember I went through that too. And I know what helped me is that I went back to my doctor and I said what wasn't working."
I don't do that either, Caddy. I don't recommend to people, what medication, or this is the right one or the wrong one. I always refer them back to their prescriber. Now, I might talk about classifications of medication.
Right.
But I think we also want to be sure that we talk about diet, exercise,
sleep.
We've talked about, I think, the importance of the recovery community. We've talked about therapy a little bit. We've talked about medication. But we also need to practice wellness in our lives and mindfulness. And we get so much stress and there's so much anxiety right now because of what has just happened in the past few days. And we just really need to be mindful and take time for ourselves and practice some self-care. So
I really appreciate you saying that. Yeah, I mean, just last night I was sitting at home. Actually, true confession, I forgot my phone at work. Oh my gosh, you would have thought the house was on fire. And I mean, that is a joke. Don't crash down on me, anybody. But I ran back to work to get my phone because I just couldn't live without it. But what I did do when I came home is I was swiping on my phone, but I came across this wonderful human who's got a garden. And he said, "You know what I want to do, everybody? I want to just have you listen to the wind in my garden."
Beautiful.
And we're talking like 30, 60 seconds, but I did it. And I didn't do that instant need to feed my brain. And you know what? To slow down, look out a window. Don't have
breathe.
Breathe. Yeah. Breathe deeply. Breathe intentionally. Talk to somebody. Listen to maybe some helpful voices or music or something. I think with the whole mental health and co-occurring and the swiftness that this world moves in, just slowing it down is so critical. So critical. Any other tips or tricks for the listeners out there? Other than make sure that if you feel as though you're off, don't feel like you have to stay in that off space, right?
Yeah, I think that's really good advice. And again, I want to just reiterate that given the prevalence of mood issues, anxiety issues, trauma issues, likely you're going to be talking with somebody else who has also had a similar experience. Mm-hmm. And I think we need to not be afraid to talk about it.
Yeah.
You know, one of the things we do when we train is there's some videos that we use and some examples that we use and how to help ourselves and how to, you know, be with somebody else who might be struggling. And I think it's important to be able to talk about that.
Yeah. You know, to that point, I want to mention one video that we play that I think has probably been one of the most profound ones. It's called My Big Black Dog, and it talks about what depression looks like from the person struggling with it and how consuming it can be. And I think there's a lot of people that don't necessarily understand depression particularly well. I know I didn't for a long time. I was just down because we just didn't have...
Well, we can't articulate it.
Yeah, but you just feel off. And, you know, and so it's called My Big Black Dog. And just don't hesitate to just pull it up and just, if you know...
It's a YouTube video. Yeah. And the big black dog refers to depression like a big black cloud hanging over. Maybe isn't the best word for the best title, but that's what they're trying to do. The big black dog is the black cloud that
can hang over.
And he uses the YouTube video uses the dog as a way to describe the impact that depression has on somebody's life.
Yeah.
And how paralyzing it can be.
Absolutely. Well, Sue, we are closing up our incredible time together.
Thank you, Caddy.
Thank you, Sue.
Thank you, listeners.
Yes, all of you out there. I just appreciate you listening to Redefining Recovery, a Recovery Revolution. We're here to just broaden the spectrum of what recovery can look like, what substance use disorder looks like, and how many ways there are to help people. So thank you for listening. Please join in supporting our mission that we have at Minnesota Recovery Connection. You could become a donor, a one-time donor. You can volunteer at our organization. Feel free to reach out to minnesotarecovery.org. Thank you for listening. Enjoy your day.
Bye.
Bye.